Hi, my name is Dr. James Park, and I'm one of the epileptologists at Hoag Hospital, and I'm here today to talk to you about epilepsy surgery and what that means and what to know about epilepsy surgery. So why is surgery considered in the treatment of epilepsy? A majority of patients are actually well controlled with medications, but there is a subset of patients where seizures are not being controlled despite trying higher doses or even multiple medications. And these people have what we call refractory or drug-resistant epilepsy. And the definition really is when patients have failed 2 or more medications at adequate doses. And these medications must have been chosen for their type of epilepsy. So making sure that a narrow spectrum medication, for instance, is not being used in someone who has generalized epilepsy, which can sometimes exacerbate things, is one scenario. Patients must have been compliant and tolerating the medication. So medications can't have been stopped because of side effects or that they were only using low doses because they were having side effects with it. Again, we want higher doses or adequate doses to have been tried and failed. And other triggers must not have affected seizure control. So meaning missing, again, the most common things, missing medications, sleep deprivation, that these things were not the reasons for seizures happening. And while brain surgery sounds drastic, it is considered because seizures are not benign, which we'll get into a little bit later. So how did the definition of refractory epilepsy come about? There was a crucial study that was done, basically taking patients from 1984 to 1997 at one single epilepsy center and just tracking them and seeing how they did after their diagnosis of epilepsy and how they did with treatment. And what they saw is about 50% of patients became seizure-free on the first drug that was tried. And taking those that failed and trying second, third, or even multiple medications, you got about another 15% or so of patients who became seizure-free. However, that left about a third of patients whose seizures were not controlled with medication. And this is where the definition of refractory epilepsy came from. Over the years, what we're seeing, though, is that we have an explosion of seizure medications that are available to us. Really from the 1800s to 1900s, that during the time that the study was being done, from then on, we're seeing this kind of exponential growth in the medications that are available to us. And many of them have better side effect profiles and different mechanism of action. So the question became, if we included these newer medications, how do the percentages change in terms of refractory epilepsy? Do we have better medications now that we see that patients can be better controlled with medications? And so what the study coordinators did was they expanded it to include patients up to 2014. And the question was, were any of these new medications better? What we see is when you break them down, again, here's the old seizure medications, and here's the study with the new medications included. And what we see is there's really no significant difference. You still see about 50% of patients being well controlled with the first medication, still about 15% or so of patients who are controlled with second, third, or even multiple medications, and still about a third of patients who are not controlled with despite trying multiple medications. So the need for epilepsy surgery has not really changed based on newer and supposedly better medications coming into the market. So as we talked about, seizures are not benign. There are many kind of factors that make us consider epilepsy surgery because these things over time can affect the patient's life. And so as you can imagine, patients who have seizures where they lose awareness or lose consciousness and fall to the ground, how injuries can happen with that. If you're doing a certain activity such as swimming or up on a ladder or whatever it may be, even crossing the street, losing awareness or losing awareness of your surroundings can be potentially dangerous. People have been shown to have declines in their cognition and memory as well with uncontrolled seizures over time. We see this with our patients who are being evaluated for epilepsy surgery when we do cognitive testing beforehand, and we see that having seizures over years can really affect that. And there's also something called SUDEP, or sudden unexplained death in epilepsy. And what this means is that seizures can cause sudden death in people. We don't always know why, but you can imagine when patients are having bigger seizures, tonic-clonic seizures, for instance, they sometimes have trouble breathing. And so if a seizure happens at night and someone's face is in the pillow, that can be affected even more. We've seen heart changes that happen when people have seizures. So SUDEP is something that happens, and epilepsy patients need to be aware of. And what we see is that patients with uncontrolled epilepsy have anywhere from a 2 to 10-fold increase in mortality. And the overall rate is about 1 case per 1,000 patients of epilepsy. However, again, when you break that down between patients who have epilepsy that is not being well controlled by medications, this rate is much higher. So while the overall rate, again, is 1 per 1,000 patients, in refractory epilepsy, that rate is going to be many-fold higher. And patients whose seizures do become well controlled actually do not have an increased risk compared to the general population. So getting control of the seizures is really the best way to prevent this. And so that's why in patients where medications are not working, we do consider epilepsy surgery, even if seizures are only happening, let's say, once or twice a year, especially if those are tonic-clonic seizures. So seizure freedom to us as epileptologists really means 0 seizures, especially the more disabling seizures. We want to make sure that they're well controlled. So what does the workup for epilepsy surgery entail? So this is an old kind of algorithm for what we thought about. So again, you have to have failed 2 or more medications, and we do what's called a pre-surgical evaluation. The main part of that is getting EEG monitoring done with electrodes on the scalp and seeing where seizures look like they're coming from with that. And additional things like imaging, neuropsychological testing, all these things are done and considered before we do epilepsy surgery. And once we figure out what type of epilepsy you have, there's kind of different pathways. So generalized epilepsies, we have things such as VNS and corpus callithonomy and hemispherectomy. These are things that are typically done in pediatric epilepsy, but are considered in generalized epilepsies. Focal epilepsy, we may need to do more monitoring with what's called intracranial EEG. So that's the placement of electrodes underneath the skull to basically try and record and capture seizures to get a better understanding of where exactly the seizures are starting. And if there is a spot that we feel like can be resected, again, it doesn't have eloquent or functional components to that part of the brain, then we would actually resect that part of the brain. However, back in the kind of the old way of thinking of things was that if it was eloquent or seizures were coming from both sides of the brain, they didn't think that surgery was possible. And so medical management, VNS, those were the only things that were possible kind of at the time. And then again, we anterior temporal lobectomy and hippocampectomy are just other types of resection that we do specifically for temporal lobe epilepsies. So how has that algorithm changed? And this is kind of a newer way of thinking of things. Again, same thing. You fail two or more medications. You do a pre-surgical evaluation, again, entailing things like EEG, imaging, neuropsychological testing. We have a lot of newer tests that we can use to help kind of determine where seizures could be coming from as well. And then again, similar things for the generalized epilepsies and pathways for focal epilepsies. And then from here, we have a new way of monitoring patients with intracranial EEG, is what we call stereo EEG or SEEG, which is a minimally invasive way of placing those electrodes. But we still use the grids and strips and things as well. And once you have an idea of where seizures may be, resection, temporal lobectomies, amygdala hippocampectomies are still considered, but we have a lot of other things that are possible now. Previously, again, when patients had eloquent cortex that was involved or bilateral involvement, we said only medical management or VNS were possible. But now we have newer devices called RNS, which is a responsive neurostimulator that can be placed. This is actually, even this algorithm is a little bit old because we can also do what's called DBS. When there's multifocal epilepsy, so meaning, two or more foci, so with two foci of seizures, RNS is possible because you have two leads. But when you have more than two, the question becomes we can't cover all those areas. So things like DBS, VNS, dynamic RNS, which is kind of a new thing that is starting to be used, or even placing two RNSs have even been considered. And in patients whose seizures are not well defined, even after intracranial EEG, again, some of these things are being considered as well. So, and possibly in the future, these may be considered for generalized epilepsies. Right now, these devices are, DBS and RNS are only approved for focal epilepsies, but studies and research is being done in patients with generalized epilepsies as well. So as we talked about, there are innovations in the pre-surgical evaluation. These are just tools that we are starting to use more and more now to help us to decide where seizures could be coming from. Because EEG on the outside of the scalp is not always able to tell us where exactly to go. And so one test that we're using more and more of, especially at Hoag, is called MEG, or magnetoencephalography, which is basically a very sensitive detectors that are able to find these small spikes, or a cluster of spikes in the brain that, let's say, a regular EEG would not be able to detect. And this allows us to kind of target certain areas with our intracranial EEG, just to make sure that we're kind of getting a sample of all the spots that we think seizures are coming from. Fmri is being used more and more as well, which is essentially seeing where functional areas of the brain are. So when someone thinks about moving, what part of the brain activates? When someone is thinking about certain words or generating sentences, what part of the brain is active during that? So making sure that we are figuring those areas out so that we're not resecting or affecting areas of the brain that have kind of functional components to it. And then there's also something called source localization, where some people can have kind of high density EEG placed, or even the EEG that is done can be further analyzed to try and figure out, is there certain spots on the brain where that seems to be more active based on the interectal findings that we have on the EEG. So all of these things help us to place the electrodes to study the seizures better. And so phase 2 or intracranial monitoring, what that entails is placing electrodes again under the skull to record seizures kind of more at the source. And so the old way of doing it, which we still do now for some cases, is using what we call subdural electrodes. So you can see here there's kind of grids with multiple contacts on it, or strips, one kind of single strip with multiple contacts on it. And you basically lay those in or slip those in under the skull and cover big areas of the brain. The limitation, however, with this is that it's only covering the surface of the brain. And so what if the seizures are coming from a deeper structure? And so sometimes with these, we would even put in what we call depth electrodes. But this requires us to basically be taking large parts of skulls off, of the skull off, or drilling multiple holes to kind of slip these strips in. Over the last few decades, I would say, or a couple decades, what has started to be used more frequently. It actually was used in Europe a lot longer than here in the U.S., but more and more centers in the U.S. are starting to adopt this. Is called Sterotectic Aeg, or SEEG. This is a minimally invasive way of placing electrodes into the brain. So instead of having to take the skull off and put electrodes over the brain and put the skull back on, what you're doing is just drilling small holes and putting electrodes in multiple spots of the brain where you think seizures could potentially be coming from. This is done with the assistance of robots a lot of times. This allows the surgeon to place electrodes a lot quicker and with more accuracy, minimizing the time that patients are under anesthesia. And the benefits of Sterotectic Aeg is, as you can see, you can sample deeper structures of the brain. Places in the brain where previously, let's say, we were not doing with electrodes, the grids and strips. The other benefit is that there's much less adverse effects associated with it. So less infection, less bleeding, it's much better tolerated by patients. So these are all benefits of Sterotectic Aeg. But again, the old way of doing things with the subdural grids and strips is still considered because this is basically about sampling. So grids and strips would cover a much larger area of the brain, or the surface of the brain. But you can see here, this only covers kind of smaller areas. So if you happen to not place an electrode where seizures are starting, you could potentially miss it. And so all of these tools are still utilized by us, and it really will depend on the case. So when we talk about epilepsy surgery, what is our goal? So as you can see here in this kind of picture, is we're looking for what's called the seizure onset zone, or the epileptogenic lesion. So this is what we're hoping to cut out, while we're avoiding things like eloquent cortex, again, places that have function, and hopefully, again, taking just this part out without affecting the areas of the brain that are actually healthy. So again, there are areas where seizures spread to and cause seizures, but those may not necessarily be where the seizures are starting from. So these are all things that we're trying to figure out with the intracranial EEG. And once you figure that out, and resection is felt to be an option, then we may decide on taking kind of bigger areas to maximize the potential for seizure freedom. So an example is, again, here you can see what's called a temporal lobectomy. So you're taking a big chunk of the temporal lobe, but also the amygdala and hippocampus here. But sometimes we may localize it a little bit better and only need a minimal resection. So this is what we call amygdala hippocampectomy. So only taking the amygdala and the hippocampus without taking the rest of the temporal lobe here. So it's what is recommended in terms of how much to take and things is really going to be dependent on what we see on the intracranial monitoring. As we said, in pediatric epilepsy, things like hemispherectomy and corpus callithonomy are things that are utilized. And that's because kids can, their brains can kind of reorganize and move function to other parts of the brain when you're young enough, versus adults that doesn't happen. So corpus callithonomy, for instance, again, is disconnecting the two sides of the brain. So here you see a track going across between the two hemispheres, and you're cutting that out, or nowadays lasering that out to basically disconnect the two sides. Hemispherectomy, as you can see here, is just taking one whole side of the brain that is felt to all be abnormal. And again, children, when they're young enough and have this surgery, functions move over to the other side, allowing this type of big surgery to be done. A newer type of surgery that we're doing more and more of, and actually sometimes being considered even before bigger resections, is what we call laser interstitial thermal therapy, or LIT, or laser ablation. So what that entails is it's a minimally invasive surgery. You basically go through a small hole and a probe goes into the area of interest, and a laser heats up the tissue and basically burns the tissue. And you can see here, as the laser is being moved back, you're creating this tract that where the brain is being ablated. And this is, for instance, this is being used in someone who has temporal lobe, mesial temporal sclerosis, but we use it also in patients who have, let's say, something like a cavernous malformation, like an abnormal tangled blood vessels, or a small abnormality like a heterotopia, or some abnormal cortex that develops that we see on MRIs. We may use something like this to basically burn the tissue rather than having to do a big open surgery where the skull is taken off and again, you're cutting out that part of the brain. So patients usually have done and can go home the next day and be back to work and things, within a week or so. So has really changed, again, how we approach surgery sometimes. Kind of the newer thing that has also changed epilepsy surgery over the last couple of decades is what we call neuromodulation. So we have a lot of different devices now that are available to us to try and help treat seizures. Vagus nerve stimulator, deep brain stimulator, and responsive neurostimulator are the three that we have. VNS has actually been around for a while. The first VNS was implanted in 1988. And what it is this little generator and a electrode that is wrapped around the vagus nerve and constantly stimulating and sending signal back up to the brain to help make changes that stop seizures. But over the years, they've actually made various updates to the VNS where, for instance, they've added heart rate monitoring and what we call auto-stim. So a lot of times with seizures, the heart rate will change, usually increase. And so when it detects a certain percentage increase, it'll stimulate and try and stop seizures. And with this, they've actually shown some better seizure control in patients that went from the old VNS to the new one. The newest device we have called Sentiva, we're actually able to now separate day and night schedules. So, for instance, let's say most of the seizures are at night, so you can change the settings just at night, and so that the VNS is tolerated better during the day. It also added this ability to program gradually increases in the stimulation, so that patients don't have to come into the office every few weeks to change it. And so, with that, you're just gradually ramping it up to the setting that you want patients to get to. And so all of these things, again, help the VNS with us dealing with the VNS and getting patients to where they need to be in terms of seizure control. There's a newer device called DBS that was just approved in the US in 2018. It's actually been used in Europe for a lot longer than that. And what it is placing electrodes into the deep parts of the brain and targeting what's called the anterior nucleus of the thalamus. So the thalamus is a major relay center for the brain, and the idea is to target this area to basically try and disrupt seizures from spreading and things. More research and studies is being done in other targets. So, for instance, the central median nucleus is something that's being studied. So how that changes seizures kind of is being studied. But for right now, again, this is the target, but we may have more areas that are being targeted in the future. Finally, the responsive neurostimulator, or RNS, this was approved back in 2013, and for adults 18 years and older, but is actually being studied in pediatrics as well right now. And what it is a small little computer, essentially, with two electrodes that can go into the brain, either a strip or a depth that gets put into the deep parts of the brain, or again on the surface like this. And it monitors the seizures or your brain waves. And as it thinks you have a if it detects something that it thinks is a seizure, and this is something that is different for every patient, and you can really tailor this detection for each patient and what their seizures look like. Once it detects it, it'll give shocks or treatments to basically try and stop seizures. With this device, what's really, how it's really changed the game is that we're getting chronic monitoring. We're getting all these EEGs basically over time and seeing sometimes that there are certain patterns, that seizures are happening at certain times of the month, or let's say certain times of the day, or with certain medications, how they change. People are actually using some of this data to try and create what are like seizure prediction models. So again, this is something that has really changed how we look at seizures now. And sometimes patients get electrodes put in both sides of the brain, and we find that actually 90% of the seizures look like they're coming just from the one side. And based on this monitoring, we may actually go ahead and do resection on that side while still leaving the electrodes on the other side. So it's really changed how we're approaching epilepsy surgery just with this available to us. So why is it called neuromodulation? The reason is that over time, what we're seeing is that it does cause changes in the brain to help seizure control. So none of these devices are curative in the sense that the abnormal brain is still there and causing seizures, but these devices are helping to control them better. But what we see that is that with over time, with more and more stimulation, we end up getting better control. So with all the devices here, see, with VNS, as you go to just more time that it's in, you get better percentage of seizure reduction. Same with the DBS and same with the RNS. And you can see here with an individual patient, what we see is that over time, their seizure control continues to get better as we continue to tailor the treatment and tailor the detection, in this case, with RNS, for that specific patient. And so these are devices that we place in patients, let's say, where resection may not be possible, but we are getting good seizure control with them, and some people even becoming seizure-free with these devices. And then what's the future of epilepsy surgery? As you can see with kind of what we've been going through or what has developed over the years is that more and more we're going to kind of minimally invasive things. So stereo EEG, laser ablation, et cetera. And so things that are currently being studied and looked into as options for epilepsy surgery are things like focus ultrasound. So without even having to drill a hole, basically using sound waves to destroy abnormal tissue that we think is causing seizures. The French have been doing this for a few years now too, what's called stereo EEG guided radiofrequency thermocoagulation. Basically, when stereo EEG is placed and a seizure onset zone is figured out, using that electrode and overheating the tissue that electrode is in, as you can see here, little spots where little burns have happened or tissue has been destroyed, to try and basically destroy the area that they think seizures are occurring without having to do another separate surgery. And they've seen some patients have reductions in their seizures with this. So these are just more and more things are becoming available to us, especially minimally invasive, to try and get better control of seizures. In summary, if you have failed 2 or more medications at adequate doses, you should really consider seeing an epileptologist to see if you're a candidate for epilepsy surgery. Like I said, the chances of a seizure medication working after 2 or more medications have failed really gets to about less than 5%. And epilepsy surgery, if in the best cases, let's say, has a 70–80% chance of achieving seizure freedom, or even in the worst cases, maybe has a 30% chance, that equation really changes. So I think when medications have failed at good doses, or even multiple medications have failed together, it's something that a patient should be evaluated for epilepsy surgery. And for patients who were considered to not be candidates for surgery in the past or had evaluations done many, many years ago, since there are newer methods for evaluating and treating refractory epilepsy, those patients are ones that should also consider having a reevaluation done. So again, even patients who have bilateral seizure onsets in the past that were not considered surgical candidates and were left to try things like, you know, just other medications and multiple medications. Those patients ended up going back into trials for things like the DBS and RNS and actually got good seizure control. And so again, those patients who have had evaluations many years ago should consider getting a reevaluation done at a level 4 epilepsy center. So Hoag is a level 4 epilepsy center, meaning we have kind of comprehensive care, everything that we need to diagnose and treat epilepsy, all the different epilepsy surgeries as we just talked about today, being available to us, and specially trained neurosurgeons who are able to do these procedures. And so again, if you have epilepsy and you have seizures that are not controlled, I would consider seeing an epileptologist at a level 4 center such as us. Thank you very much.
Hi, everyone. That was the end of Dr. Park's presentation. We do have Dr. Park with us here today. If you have any questions, please, you can type them in or you can speak up.
That's okay. Well, like I said, hopefully this was a informative talk. If anyone has questions, you're free to contact us at Hoag, and you know, either Sheena or myself or whoever can always kind of get back to you with the answer. Yeah, like I said, hopefully you found this information helpful, and again, we're kind of at therefore as a resource if needed.
Thank you, everyone. We will be back at 11 o'clock with the presentation from our neurosurgeon, Dr. Mehta. He will be presenting on exploring some minimally invasive surgical options for seizure-free life. Thank you.
All right, have a good one.
Thanks.